Bismillahirrahmanirrahim. Final year. Today we are going to study the urological oncology, and today's topic is bladder cancer. Previously, I think you have already studied CA prostate, and today's topic is bladder cancer. So let's have a brief look on what is the incidence, what is the etiology, and what are the investigations of choice. How can we assess what is the Tnm staging of the bladder cancer, and how will you treat such a patient, and what is the prognosis of patients which are suffering from bladder cancer. So let's start with the bladder cancer. So incidence is a little bit higher in males as compared to females. There is a ratio of 3:1. That is, for every 3 males having this disease, there is only 1 female, and we will later on see that why this percentage, why this incidence is a bit higher in males as compared to females. We will later on discuss it in the etiology, that according to causative factors, what predisposes males more than the females. Incidence of bladder malignancy increases with advancing age. It means that the uh, that the population which is younger, they have got less chances of getting this disease, whereas the population which is having more advanced age, they have got more chances of having this bladder carcinoma. It is the fourth most common cancer in men and 10th most common cancer in women. So its incidence is it's quite prevalent malignancy in males, getting the fourth number. That is, after 3 most common malignancies, this is the fourth most common malignancy in males, and it's the 10th most common malignancy in females. Almost all bladder cancers are urothelial in origin. It means it is originating from the urothelium. Urothelium is the lining which is lining the bladder and the ureters and the renal pelvis. So renal pelvis, ureters, and bladder, all of them are lined by the transitional epithelium, which is multi-layered epithelium. So most of them originate from this urothelial epithelium. Let's briefly discuss about the etiology. The number one cause is genetics. That is, if you are having a first degree relative which was having this disease earlier, you are predisposed to develop this malignancy. So genetics play an important role in the development of this disease. Second most common cause is smoking tobacco. So previously I told you that this disease is more prevalent in males as compared to females. So here comes the cause of this prevalence, that why 3 males are affected as compared to 1 female. This is because of cigarette smoking, because mostly in our society and worldwide, the smoking incidence is higher in males as compared to females. That's why the males are more commonly affected by uh, this bladder cancer, because of this smoking. It is proposed that nitrosamines, naphthylamines are secreted by the kidney in urine of the smokers. So basically, these are the carcinogenic compounds, nitrosamine and naphthylamine, which are secreted, which are the which are present in the smoke of the cigarette, and when the smoker inhales, it is transported into the blood, and later on, when this blood is filtered by the kidneys, these two compounds are excreted by the kidneys, and they are then present in the urine. So when these carcinogenic compounds which are present in the urine, when they come in contact with the urothelium, that leads to the metaplasia, and this metaplasia later on is converted into the malignancy. So cigarette smoking is one of the major cause of cigarette smoking is one of the major cause of developing this carcinogenic. So it's a take home message for all the smokers that this disease is basically a smoker's disease, because whenever a patient comes to us in outpatient department with hematuria, and we make a provisional diagnosis that this patient is uh, suffering from bladder cancer, our next question is, do you smoke? So most of the time, in our observation, it is present that 90% of almost 90% of patients who present with the bladder cancer, they are either active smokers or passive smokers. So active smoking as well as passive smoking, both are dangerous. That is, if a person is smoking in the same room where you are sitting for a long time, and you also inhale that smoke, you are equally predisposed to all the hazards which are imparted by the cigarette smoking. So active and passive smoking both impart a higher incidence rate of bladder cancer. So bladder cancer is basically a disease of smokers. Third most common cause in etiology is occupational. That is, the patients who are working in some sort of which are exposed to certain carcinogenic chemicals during their working hours, like the patients who are working in paint industries, dyes, inks, or leather maturation industries, petrochemicals, rubber and tires, textiles, trucks drivers, or persons working in printing industry. So the third most common cause is so mechanism is again the same, that the people who are working in such chemical industries, they are actually these chemicals are present in fumes, in the form of fumes in these industries. Whenever the patient inhales those fumes, these fumes and their toxic chemicals, they are then transported to the blood, and from there they are going to the kidneys, where kidneys excrete these chemicals into the urine. And when this urine with chemical compounds comes in contact with the urothelium, it leads to the initiation of carcinoma, leading to metaplasia and ultimately the carcinoma. The fourth most common cause is infection, particularly the infection with a parasite called schistosomiasis. And that schistosomiasis is basically lives in the vesical plexus and lays eggs there, and leads to the chronic inflammation of the bladder epithelium. And this chronic irritation and inflammation leads to the metaplasia formation, and this metaplasia leads to ultimately the carcinoma. Number fifth common cause are the vesical calculi. Vesical calculi, again there is the same mechanism, that is the presence of vesical calculus inside the bladder. It leads to the chronic inflammation and irritation. This chronic inflammation and irritation may lead to the formation of leads to the metaplasia, and metaplasia leads to carcinoma. So in etiology, as we have already discussed, that number one is genetics. That is, if your first degree relative is suffering from this disease, then you might be at a risk of developing this disease. Number two, cigarette smoking. Number three, occupational hazards. People who are working in the chemical industries, they are more prone to develop the CA bladder. Number four are infections, particularly with schistosomiasis. Schistosomiasis infection is not very prevalent in our country. It is more prevalent in the Gulf areas like Kuwait, Saudi Arab, UAE, etc. They are more common over there. So whenever a patient with schistosomiasis presents to us, usually these patients have got traveling history to these Gulf countries. Vesical calculus formed, either they are primary vesical calculi or secondary vesical calculi. They both of them can prone the patient to develop the bladder malignancy due to chronic irritation. So how do the patients with CA bladder, they present to us? Mostly 80 to 90% of patients with the bladder malignancy usually present with the painless gross hematuria, which is the classic presentation. Painless is particularly point to be noted that the patients usually which have got malignancies, urological malignancies, either renal cell carcinoma or transitional cell carcinoma of the renal pelvis, transitional cell carcinoma of the ureters, or transitional cell carcinoma of the bladder, they usually present with painless gross hematuria. It means that the patient is not having any pain and is having gross hematuria. Gross means visible. So this is the classical presentation. Patient usually comes that डॉक्टर साहब मुझे दर्द कोई नहीं है लेकिन पेशाब में खून आ रहा है. So painless hematuria immediately draws our attention to this serious disease, that is the malignancy. So if a patient with painless gross hematuria comes to you, then it is most likely that this patient is suffering from some urological malignancy. As we have already studied about the symptoms and signs that a urological patient presents, we have seen that the patients with hematuria is of two types, that is microscopic hematuria and gross hematuria. Microscopic hematuria is a type of hematuria which the patient cannot observe. It means the patient cannot see. Whenever you get a urine examination of the patient, then you come to know that this patient is having microscopic hematuria. Whereas gross hematuria is a type of hematuria in which the patient usually presents to you by himself that he is passing blood through the urine. So painless gross hematuria is usually the first symptom that a patient presents with in case of CA bladder. 20 to 30% of patients with bladder cancer experience irritative bladder symptoms such as nocturia, urgency, frequency of urination. So 20 to 30% of patients with bladder cancer can present with the other symptoms like nocturia, which is frequency of micturition at night time, and urgency means extreme urge to void. Whenever patient feels desire to micturate, he or she will have to rush to the washroom, otherwise he or she may leak the urine. So this is called urgency. Extreme unstoppable urge to urinate is called urgency. And then comes frequency of urination. Nocturia is the frequency of nighttime micturation, whereas if you write about frequency, it means daytime micturation. So frequency of urination, more advanced muscle invasive disease or CIS. Frequency of micturation is usually present in cases of advanced disease, that is if the patient is suffering from T3 or T4 or is having carcinoma in situ, then frequency of micturition is more prevalent. And if the patient is having more advanced disease, that is T3 or T4 with advanced disease, they can usually present with pelvic or bony pains because of metastasis, lower extremities edema from iliac vessel compression. That is, whenever the patient is having advanced disease, he has got pelvic lymph adenopathy. This pelvic lymph adenopathy leads to the iliac vessel compression, and this iliac vessel compression, iliac vein compression leads to the stagnation or pooling of the blood in the veins of the leg, and that leads to the edema of the legs. Upper tract symptoms like flank pain from ureteral obstruction. If the patient is suffering from a bladder growth that is present either close to one of the ureteric orifice, that is either the right ureteric orifice which is opening in the bladder or the left ureteric orifice which is opening in the bladder, it may impair the drainage of the urine. That is, if the ureteric orifices are involved by the malignancy, it will lead to narrowing of the ureteric orifice, and this narrowing will lead to the pooling of the urine in the upper tract, that is kidneys and ureter, leading to hydronephrosis and hydroureter. And this hydronephrosis and hydroureter will cause the symptoms like flank pain. So, if the patient with the CA bladder presents with the flank pain, it means he or she is suffering from the advanced disease, and this disease is more close to the ureteric orifice and causing the ureteric obstruction. So, how will you work up a patient who is suffering from CA bladder? So specific workup includes CBC. CBC will show us the extent of hematuria. That is, if the HB of the patient is very low, it means he or she is suffering from more extensive disease and more extensive hematuria. So HB is very important, and TLC count is very important in case of CBC. So particularly CBC, you will look for HB of the patient. That is, if you are proceeding for surgery, whether you need blood transfusion before surgery or during surgery. It will give you a rough idea of HB will give you a rough idea of how extensive is the disease, that how much patient is having hematuria. And then the TLC count will give you that whether the patient is having some superadded infection or not. Then comes urine analysis. Urine analysis is also very important. It will also give you some clue, like it will tell you the extent of the hematuria, whether hematuria is single plus, 2 plus, or 3 plus. So that is extent, mild, moderate, or severe. And it will also give you a rough idea of the infection. If the leukocyte estase or nitrites is positive, it means the patient is having infective etiology. Simply, a cystitis can lead to hematuria, urethritis can lead to hematuria. So, if the patient is having these inflammatory markers present in the urine, that is leukocyte estase and nitrites, which is present in the chemical analysis portion of the urine complete examination, then it will give you a clue that the patient is having some infective etiology of this hematuria. Then on the third number comes urine cytology. That is, you will examine the urine under the microscope and will look for the malignant cells. So if the patient is passing the malignant cells, that the patient cells which are present in the urine have polychromasia or other signs of malignancy, that is more mitotic figures, disturbed nuclear to cytoplasmic ratio, which are the markers of the cancer cells. So if you encounter such cells in urine cytology, it will reconfirm your diagnosis, that is the patient is suffering from urological malignancy. Then comes the most commonly prescribed non-invasive investigation, which is abdominal ultrasonography. You will carry out abdominal ultrasonography of the patient which is having gross hematuria and any other urinary symptom. You can look for both kidneys, whether this blood is coming from any tumor which is located in the kidneys or ureter, renal pelvis, or bladder. So abdominal ultrasonography will give you a clue that whether this blood is coming from any malignancy inside the kidneys, ureter, or bladder. So these are the three most common sites of malignancy. Abdominal ultrasonography is a non-invasive and readily available investigation, which will immediately give you clue. But but to pick up the bladder malignancy, you will have to fill the bladder of the patient so that the malignancy becomes apparent. Otherwise, if the bladder is empty, you will not be able to appreciate the malignancy. Next important investigation that you can carry out in case of bladder tumor is CT abdomen and pelvis. It will give you a very clear-cut idea of the exact tumor burden, the extent of the disease, that is the staging of the disease, and it will also give you an idea of the distant spread or distant metastasis. It will give you an idea whether the disease is locally spread, disease has got local spread, or it has also migrated or metastasized to the distant organs. Next important investigation that we can carry out is MRI, magnetic resonant imaging, and it can also, if the CT is inconclusive or you are not getting the complete information from the CT abdomen and pelvis, then you can advise MRI. And ultimately, the cystoscopy, that is flexible and or a rigid cystoscopy, it will give you a very clear-cut idea. Cystoscopy can be diagnostic as well as therapeutic. That is, you will go inside, you will examine the tumor with the cystoscope, and then you can immediately do the resection in the same sitting. That is, you can it can be therapeutic as well as diagnostic. You can do the resection of the tumor, and later on you can send that tissue for the histopathological examination. Next comes the Tnm staging. It starts with CIS, that is carcinoma in situ, which is a flat lesion. But CIS is usually more aggressive than the papillary growths. So papillary growths are usually, here you can observe that we have posted some pictures. These are the cystoscopic pictures of the cursor कैसे आता होता है? Cursor pointer नहीं पता. So ये mouse से भी शायद आ जाए. So these are the cystoscopic pictures of transitional cell carcinoma of the bladder, which are taken with the cystoscope. Here you can see the tumor load. These are the tumors. These are the tumors. And here you can appreciate that this tumor is you can see that the tumor load is present inside the bladder, and these all of them are the papillary growths. So in case of TA, non-invasive papillary growth, T1 is up to the tumor, up to the lamina propria, and T2A is superficial bladder invasion, and T2B is deep muscle invasion. T3B is T3, T1, let's start again. TA is non-invasive papillary, T1 is up to the lamina propria, T2A is superficial muscles, T2B is deep muscle, T3A is microscopic invasion of the perivesical fat, and T3B is the macroscopic. Please note the difference, microscopic and macroscopic. T3B is the macroscopic invasion of the perivesical fat, whereas T4A is the local invasion, lower end of the ureter or prostate or seminal vesicle. So T4A is the locally advanced tumor which has captured either the lower end of the ureter or it has captured the prostate or the seminal vesicle, whereas T4B is the tumor which has got distant spread. It means it has spread into the distant organs. So this is the diagrammatic presentation. Here you can appreciate that this is TIS, which is the flat lesion. TA is the tumor which is limited to the lamina propria. T1 is superficial muscle invasion. T2 is deep muscle invasion. T3A is microscopic invasion of the perivesical fat, whereas T3B is the macroscopic invasion of the perivesical fat, and T4 is either the locally in locally advanced tumor, is either the locally advanced tumor, or the tumor has spread either to the distant organs. So how do you classify a patient with transitional cell carcinoma? 90 to 95% of tumors which are present in the bladder are transitional cell carcinomas, whereas the other category, which accounts for only 5 to 10% of cases, is non-transitional cell carcinoma, and it is either adenocarcinoma, posterior wall, urachus, squamous cell carcinoma, or schistosomiasis or stones, mixed type. So adenocarcinoma, squamous cell carcinoma, or mixed. So these are the three varieties which are present in addition to the transitional cell carcinoma, and they account for only 5 to 10% of cases. Adenocarcinoma is usually present in case of posterior wall or urachus, whereas squamous cell carcinoma are mostly due to the chronic irritation, can be caused by schistosomiasis or stones. And next category is mixed. So what are the treatment options available? We have got to treat the patients suffering from bladder malignancy. Treatment depends upon the stage of the tumor. That is, the treatment is mostly divided into two categories. The patients who are either suffering from CIS, or they are suffering from T1, T1 disease, up to T1 disease. They have got different treatment, whereas patients with the disease T2 and greater, they have got different treatment options available. So this is how this TNM staging differs, or TNM staging impacts the treatment. That is, the patients having the disease up to T1 have different treatment options available, whereas the patients which are having the disease T2 and greater, they have got different treatment options available. So TURBT, in case of superficial bladder cancer, that is the patients which are having the bladder malignancy up to T1. Up to T1 is mean the patient has got only superficial muscles involved. That is the epithelium, lamina propria, and superficial muscles. Only the patients which are having the disease extent up to the superficial muscles, which fall into the first category of superficial bladder carcinomas. In case of superficial bladder carcinoma, you can offer the patient TURBT, that is the abbreviation of transurethral resection of bladder tumor. That is plus deep muscle biopsy and superficial biopsy, bimanual palpation and surveillance. So patient will undergo TURBT, that is transurethral resection of bladder tumor, and then after this we will take the biopsy of the superficial muscles, and we'll also take the biopsy of the deep muscles from the same site of TURBT, and we will also perform the bimanual palpation and surveillance. After the TURBT, the patient will undergo the intravesical immunotherapy, that is usually done with the BCG, or we can also go for intravesical chemotherapy with mitomycin C, MMC. So after TURBT, in case of superficial bladder tumor, after TURBT, you will have to either go for intravesical immunotherapy or intravesical chemotherapy. Intravesical immunotherapy is usually done with the help of BCG, Bacillus calmette-guerin, which is also an live attenuated bacteria of tuberculous bacteria, which are usually given as intradermal injections to induce immunity. But in case of intravesical instillation, they are usually inserted in the bladder in higher dose. So 80 milligram of BCG is instilled into the bladder, 80 milligram. And usually we do intravesical instillations weekly for 6 weeks. That is, 6 injections are inserted into the bladder. So TURBT plus intravesical BCG of intravesical BCG is the treatment option available for superficial bladder tumors. Intravesical chemotherapy with mitomycin has got less role as compared to BCG. So usually in latest research and in papers, usually the TURBT with intravesical immunotherapy is the treatment of choice for superficial bladder cancers. For muscle invasive disease, that is T2 and greater, that is the disease which has either involved the deep muscles or it has microscopically involved the perivesical fat, or macroscopically involved the perivesical fat, or it has got a locally advanced disease, or the disease has been already spread distantly. So for these patients, that is T2 Tnm staging, T2 and greater, then the treatment option is cystectomy and diversion. That is, we remove whole of the bladder with the perivesical fat and lymph nodes, and then we divert the urine. Later on, we will see that how we can divert the urine. And then we also go for radiotherapy and chemotherapy. In case of superficial bladder cancer, that is up to T1, we do not offer the local radio or chemo, but we prefer intravesical instillation of immunotherapy or chemotherapy. But in cases of advanced disease, that is T2 and greater, we go for cystectomy and diversion with radiotherapy and chemotherapy. So in case of cystectomy, you can go for partial cystectomy for growth which is present on the dome, followed by the radiotherapy. If the advanced disease T2 or greater is present on the dome of the bladder, then you can go for the partial cystectomy. That is, you just remove the dome of the bladder, and it will lead to the cure, but you will have to later on go for the radiotherapy. Next is radical cystectomy in male. These are the organs which you will have to remove in radical cystectomy. In male, you will have to remove the whole of the bladder, peritoneal attachments, prostate, seminal vesicle, perivesical fat, and local lymph nodes. So this is called radical cystectomy. That is removal of bladder, peritoneal attachments, prostate, seminal vesicles, perivesical fat, or local lymph nodes. The whole of these things and block are removed in case of radical cystectomy. And for the lesions which are distantly metastasized, we use radiotherapy. In case of female, if you have to perform the radical cystectomy, you will have to take out the bladder, peritoneal attachments, the perivesical fat, ovaries, uterus, and anterior vaginal wall as well. So you will have to remove all of the organs which are closely related to the bladder to avoid any local spread later on. So T2 disease is a more advanced disease with more aggressive treatment option available. You will have to remove the bladder with the adjoining organs, and you will have to go for radiotherapy, chemotherapy later on. And ultimately, whenever you remove the bladder, you will have to give some sort of the drainage, alternate drainage option in the form of diversion. So these are some of the diversion options that are broadly divided into two types: internal divergence or external divergence. In internal divergence, if you dissect both the ureters, will have to dissect both the ureters, and you will have to implant them into the sigmoid colon. This is called ureterosigmoidostomy. That is the internal drainage. That is both ureters which you have dissected and separated from the bladder, because you are going to remove the bladder. Then you implant both ureters into the sigmoid colon, forming ureterosigmoidostomy. So both the urine and the fecal matter will come through the anus. Again, I repeat that if you do the ureterosigmoidostomy, because you have to remove the bladder, you implant both ureters into the sigmoid, and both the urine drainage and the drainage of the fecal matter will be then from the anus. So the fecal matter will be mixed with the urine. External diversions are the ileal conduit. It means that is, you create a pouch, you separate a segment of the ileum from the gut and make a conduit of it, just make a passage of it. You implant both ureters from the right kidney and left kidney. You implant both ureters into that ileum, patch of the ileum, and then take out that ileum as a stoma, like ileostomy. So then you will have to put an ileostomy bag over that, the ileostomy opening. So urine will be drained from that that ileal conduit into that drainage bag, which is located externally. That is why this is called external diversion. So both ureters are implanted in a dissected out piece of ileum. This piece of ileum is separated from the rest of the ileum. Here you can see the anastomosis shown. That is, you take out this segment of ileum from the rest of the ileum, and then you take out one end of this ileum is closed, and the other end is taken out as stoma, like the ileum ileostomy, and then you attach a bag over that ileostomy, and it will lead to the external diversion. And then there is a third variety of divergence, which is called the continent divergence, like new bladder formation. In this case, new bladder formation, again, you will have to dissect out the piece of ileum, and then you will refashion that piece of the ileum into a bladder, and will attach that bladder either to the urethra or take the opening outside, and the patient will insert the catheter, because this ileum will not contract like the bladder, so it will not automatically expel the urine which is present in it. So after 3 to 4 hours, patient will have to insert a Nalaton catheter in that new bladder and will evacuate that bladder. So what is the prognosis? Superficial bladder cancer. The risk of progression defined as an increased tumor grade or stage depends primarily on the tumor grade. So the risk of progression increases with tumor grade as follows. The grade 1 is 10 to 15% risk, grade 2 14 to 30%, 37% risk, and grade 3 are 33 to 64% risk. CIS carries a poorer prognosis and a recurrence rate of 63 to 92%. So diffuse CIS, ominous findings with more than 70% progression to muscle invasive disease. So whenever the grade of the disease increases, it leads to poor prognosis. In case of TNM staging, the 5-year survival rate decreases with increasing stage as follows. That is, whenever the stage increases, the 5-year survival decreases. With more aggressive disease, more advanced disease, you will have a poor 5-year survival. So the 5-year survival rate decreases with increasing stage as follows. In case of TA, T1, CIS, usually the patient will have 82 to 100% 5-year survival rate. whereas in case of T2 disease, you will have only 63 to 83% 5-year survival. In case of T3A, you will be having the 67 to 71% 5-year survival. In case of T3B, 17 to 57% 5-year survival rate. And in case of T4 disease, that is more advanced disease, you will have only 0 to 22% 5-year survival. So, whenever the stage of the disease increases, the prognosis decreases. As I showed you before, that is the grade of the disease also impacts the risk progression. Whenever the grade of the disease increases, the risk also increases. Whereas whenever the stage of the disease increases, the 5-year survival decreases. TA has got 82 to 100% survival rate, whereas T2 has 63 to 83%, T3A is 67 to 71%, whereas the T3B is 17 to 57% survival, 5-year survival rate, and T4 has got 0 to 22% survival rate. Prognosis for metastatic transitional cell carcinoma is dismal, and only 5% of patients living 2 years after diagnosis. Early diagnosis and improvement in treatment of bladder cancer may be responsible for the improved survival rate of patients with TCC. So, likewise, in other malignancies, the same rule applies over here. That is, if the patient presents earlier and you diagnose earlier, treatment options which are available is offered to the patient earlier, and patient responds to these treatment options and strictly remains adhesive, compliant to the treatment, then he will have a better prognosis. Whereas if the patient is having a careless attitude, then he will soon land in trouble. So that's all from today's lecture. Question answer. So now we will have a brief period in which वैसे कर दें, चैट पे कर दें जैसे भी है चैट पे कर दें. So we will have now a brief question answer session in which you can answer any question.